So now this is the T2 image. Now remember, for masses, MRI is much better than CT. Why? Because you can see the soft tissues. Secondly, you can see the enhancement pattern well. CT is actually needed only predominantly for the bones here, right? For erosions and all. Now, if you look at the T2 image here, this is the axial image and this is the coronal image, right? You can see that there is a T2 hypointense structure, right? Which is giving this cerebriform kind of appearance, right? The epicenter of this lesion is somewhere within the sinus and it is extending into the nasal cavity. So this is like a papilloma, right? Which is extending from the maxillary sinus into the nasal cavity. Okay. So this kind of appearance you can actually see on T2 or you can see it on post-contrast images, right? So this is how you will be appreciating the papilloma. Now, important thing to note here is all the bony lines are intact, right? How do I say on MR that the bones are intact? So it is kind of a extrapolation because all these T2 dark lines, these are the cortices of the sinus walls, bony walls. And we see that this particular lesion has expanded the OMC. That is why I keep saying that you have to see the drainage pathways always. As soon as there is an expansion of any of the drainage pathways, and yet it is obstructed. What does it mean by obstruction? Can you see the fluid signal intensity here? This is a T2 weighted image, right? Now we have already discussed so much MR that we all understand that these are T2 images. And for T2 images, you can see that this particular lesion is causing an expansion of the OMC, yet there is some fluid signal intensity in the dependent area. So that means that there's still some fluid getting accumulated here, and this mass is causing obstruction here. So obstruction of the drainage pathway with expansion means you're looking at a mass. Even if you have just a CT, go ahead and you can get a CMRI for correlation and for finding out what this is. This kind of appearance, right? Like this. So that is a papilloma. Okay. This particular pattern can be seen. I have picked up the images of T2 where we can see it very well. You can also see it well on a contrast, right? Next, let's move on to another example. Now, let us look at this. Okay. So, first of all, I will tell you that this is the T2 sequence. Next, we are able to see that there is this round, lobulated, irregular kind of mass. Note that it is not limited to the sinus now. Firstly, you cannot appreciate the walls here. यहाँ तो wall ही नहीं दिख रहा है. The sinus wall should have been here, 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 right? Can't see it. Also, you cannot appreciate the boundary of the sinus here. This mass is clearly outside it. So there is a invasive component here. And it is irregular in shape, right? So once these two things have happened, now we are moving into a direction where we think that yes, this can be a tumor. So first of all, look at the T2 signal intensity is more dark. There is a little bit of fluid adjacent and we see that it has caused an erosion and extended beyond. अब इसको confirm करने के लिए what do? We do a CT. Right? Can you see on CT? These are some arrow marks. There's no bone here. It's gone, completely gone. Right? So these are not pressure erosions. You can also see the outline of the mass here. Right? So these are not pressure erosions because your mass is extending beyond the bony outline. Yahan pe whatever bone was here in these places has all been eaten away. Right? And if I'll show you another finding here on CT. If you look at this fat, can you appreciate this fat here? Even though it is a bone window, you can see that there is some hypodense area behind the sinus, which however is not there here. Why is it not there? Because our mass is sitting in there. Got it? If you look at a brighter signal, right? If you are looking at the contrast images, you're able to see that this thing is enhancing, right? This is an enhancing tumor. If you see here, this particular tumor, so this was the axial section. This is your coronal section. You can very well appreciate that yes, the mass is still within the maxillary sinus, but I cannot see the medial wall, cannot see the roof of the maxillary sinus, which is forming the floor of the orbit. We cannot appreciate it. Rather, we can see that it is extending into everything adjacent. In the last case, compare that we are able to see the entire anatomy well. Even though our OMC is expanded, still we have an outline of the OMC to understand that this is expanded. Look at it here. Can you appreciate? Like on the other side, you can. Can you appreciate anything here? No, we cannot appreciate anything here. So what has happened here is that there is an proper erosion here. Also, the wall around here, somewhere we're expecting it here, but this has gone out as well, right? So it's gone into our masticator space of the infratemporal fossa, right? It has gone into the orbit. Can you see? This is the muscle. This is the inferior rectus muscle in the orbit, which is being partially lifted up and is showing loss of fat plane. So this muscle is going to be stuck there to this mass. OMC is destroyed. It has extended into the nasal cavity. Okay, on MR, these are going to be the dark lines of the cortex. So it's all gone on this side. It's all gone on this side as well. Okay. Even the floor is not very well seen. So whenever you have this osseous destruction with an expansile mass which is enhancing, you can think of an adenocarcinoma. I would rather say that you should put in first like a malignant etiology. Then you may or may not give differentials of such histopathological diagnosis. There's no need. Next, if you look at another case, so till now, both these cases are clear, papilloma and an adenocarcinoma. So I'm trying to keep some time for the case, which I said I will show you. So for the masses, I'm showing images of these masses, right? Primary focus being on reading the images, okay? If you see here, now this is another case, okay? What is happening here? Let's try and see. So here, there is a proper mass here. Can you see? Can you appreciate this mass? Right? And this mass is kind of involving the posterior ethmoid air cells. Like this is the place where this is going to be epicentered. What is this place exactly? This is your cavernous sinus on an axial image. Let's see a coronal image. Can you now appreciate? This is your normal appearing cavernous sinus. This is your cavernous ICA. Okay. So once your cavernous ICA is here, your cavernous sinus is here. Does this cavernous sinus look same? No, it does not look same. What image is it? It is a T1 weighted image. So I am saying that on plain MR itself, without contrast, you can still say that there is something abnormal in this region, right? So for example, what you are seeing here is that there is an abnormal tissue here. All of this. And just in relation to cavernous sinus, you have which sinus, which paranasal sinus? You have the sphenoid sinus and you have the posterior ethmoid air cells. So epicentered there, it is extending into this area. Can you appreciate this? So here we are able to see a cavernous sinus involvement. And that too on a plain MR. If you look at it on the T2 weighted image, this particular area, it is mildly T2 low, right? In this, you can see that it is kind of sitting in the center as well as extending into the left-sided cavernous sinus. It is reaching up to what point? The orbital apex. These places are in continuity with each other. So whatever is going to involve a cavernous sinus can also extend further into the orbit. What happens in the cavernous sinus region? There are multiple nerves which are also moving in there. Cavernous sinus ka wall mein also there are nerves which are going along, right? Right? You have the third, fourth, fifth divisions you have. Okay. So in that way, all these nerves, and there's some plexus around the ICA also. So all these nerves are also there. Now, if you look at this soft tissue on the post-contrast images, this whole thing is enhancing. Also, this enhancing structure is also extending into the masticator space. What is this space? The masticator space in the infratemporal fossa. So whenever you have this kind of extensive spread, again, we are down to a malignant. So you have to see for the epicenter of the mass. Sorry, I saw the question a bit late. But for the mass, you have to see where the epicenter is, whether it is within a paranasal sinus or it is in the nasal cavity. For example, I will show you in this tumor. Where is most of the mass lying? Most of the mass is lying within the sinus region, right? So that is why you can say that it is a sinus mass which is extending into the nasal cavity. There are some other specific signs also, like you can actually see for which vessel is supplying it. Either it's the nasal cavity ones or it is coming from the lateral side. Those are soft pointers. But main thing is an epicenter, right? Bony destruction will also be closest to the epicenter. That is how you can tell whether it's an invasive nasal mass or a sinus mass. So here you are able to see that this mass can extend into the cavernous sinus, which is a dural venous sinus. It is going into the masticator space here. We are all aware about the spaces of the neck now, right? So here what is happening is that it is kind of a perineural spread because it is extending along the cavernous sinus and the likely nerve roots. So that is how we are saying that there is a perineural spread. If you find a similar kind of pattern, you can suggest there's an adenoid cystic carcinoma possibility, but you can actually just say once it's biopsied, right? You also see that there is a background of sinusitis disease in both the ethmoid cells, right? Next, as I said, there can be neuroectodermal tumors. For neuroectodermal tumors, I know this is a very heterogeneous topic, which is very hard to understand, but always think in terms of if I find a tumor in this region, how am I going to think of differentials? And what are those possible differentials? So first we talked about benign versus malignant. Now we are talking about each of the examples. So if I find a benign thing, I'm thinking of a papilloma. If it is enhancing in a cerebriform pattern, it can be seen in any of the sinuses. I'm giving you an example of a maxillary sinus, right? Next, whenever we see a mass which is extending into places with a lot of enhancement, right? This is an adenocarcinoma of the maxillary sinus. One thing is clear, again, it is going everywhere in the adjacent areas. But another example I'm showing here is where it is extending into the dural venous sinus, that too in an expected location from where the nerves come in. Is this the skull base? Is it? And what does travel from the skull base into the face and neck region are the nerves. So whenever there is this kind of pattern of the tumor, you have to think about a perineural spread, and which is very common in salivary gland tumors, especially adenoid cystic tumor. Okay. With those things in mind, now we are moving on to tumors which are going to be epicentered again. What area is this? This is your anterior cranial fossa. We are drawing a coronal image. This is your nose region, right? So you have your ethmoid air cells here. You have your olfactory grooves here. You have your crista galli here. And if your epicenter is somewhere here, then you can think of a neuroectodermal tumor, which is esthesioneuroblastoma. So there can be minor salivary glands in the linings of the sinuses as well. Right? So what happens is these are these small. So the reason to discuss it tissue origin wise is so that you don't forget. है ना? So these smaller minor salivary glands can be lined at multiple places, right? They can secrete any kind of secretion. So smaller ones are present at multiple places. So that can also extend into your sinuses, and then it can have a perineural spread. So this last case was a salivary gland origin adenoid cystic carcinoma. But its extent is such that it is involving the paranasal sinuses as well as a perineural spread. Right? This one is actually a sinus mucosal wall originated adenocarcinoma, which is extending everywhere. Right? Now, if we move on to the neuroectodermal tumors. So, because the reason to approach these tumors again, now we are seeing where our epicenter is, right? But this is a peculiar tumor, can come as a spotter, can be given as a long case also. So, CP is what? Craniopharyngioma. So, no, I would rather say that oh, right. Yes, yes. So this is the cribriform plate. Very good. This is the anterior cranial fossa. The central part is the cribriform plate. You have ethmoid air cells in this region apart from the nasal cavity, right? These are both the lamina papracea, the walls of the orbit. And now you have something which is sitting over here, right? If I look at just the T1, okay, this is just the T1. Why am I saying is it the T1? Because whatever brain parenchyma I can see, white matter is white, gray is gray. No sheath which is bright around the optic nerve. So fluid, non-sensitive sequence. So this is a T1 dark area, okay. And when we see it on an axial T2, we can see that it is pretty bright. Next, we are seeing that it is having an intracranial extension. Till now, we were seeing masses which had gone into the adjacent masticator space, buccal space. It had gone into the dural venous sinus. It had gone into the orbital apex. But this time, there is a frank intracranial part which we can see across the cribriform plate, which is also enhancing. There are some peripheral cystic areas, and there is an enhancement in the central region. Non-enhancing cystic parts, central is enhancing, solid enhancing tumor. So this is an esthesioneuroblastoma. What happens here is that you're going to find peritumoral cysts, and it is going to be epicentered at the olfactory grooves. Takes origin from the olfactory bulbs. Right? So this is the epicenter of the tumor, extends both ways, intracranially as well as into the nasal cavity. So this is a very good example where you see peritumoral cyst, bright on T2, homogeneously enhancing, and T1 hypo. Got it? This is esthesioneuroblastoma.